on with your presentation regarding the integrated systems. You're recognized now.
Okay, thank you, Mr. Chair. I think in New Mexico we spoke of, I'll go to continued challenges. I think this is important because when we spoke to them, they identified some challenges. And it's not unfamiliar territory for you all here when you look at it. So the challenges and advice on implementation of integrated systems is use the best resources from the field offices, seasoned workers adjusting to additional information gathering, trusting new systems, allow for time and data conversion, and clarify roles with the vendor. This is all being obviously being worked on now, and some of it already has been. Need testing with live data for reports and interface, allow time for organization knowledge transfer, clean up notices before converting to a new system and transferring code to another state. And again, this is in the status report, so this will all be available to the department as well. Pennsylvania has a single application as well for SNAP, cash assistance, long-term care, home and community services, all integrated, the development disability system as well. It integrates Magi methods and exchanges data with other online systems. High level of eligibility screening offers an opportunity to add healthcare. Individuals can submit verification documents electronically. One other thing with Pennsylvania, I know that Representative Collins felt strongly about that eligibility hub idea. I actually did some work with Pennsylvania on an advanced planning document there that they were able to get about $26 million in federal funds to enhance their systems by adding eligibility, public integrity type integrated systems. So there's something you could look at. The department here could use that Pennsylvania model if the task force recommended and it became legislatively created to do any type of eligibility hub, or excuse me, enterprise hub. And this would be on public program basis. Pennsylvania told us the lessons learned, no matter how simple a particular enrollment or renewal strategy may seem, will never work for everyone. Must be a range of mechanisms and choices available. Flexibility to make mid-course process correction is key. And that's something that Martha has really been so steadfast in believing, because there's a number of states where once you get started down the road, it's so hard to make changes, and it costs so much money. So early on, think about how you want to be as flexible as possible in making changes. And small-scale testing of new practices enable development of workable solutions. Community and consumer advocates play a critical role. And this is the final slide on this integrated systems analysis and review we've done. The importance here is the executive level leadership across agencies to provide governance. One thing's for sure, the governor has obviously expressed interest here and shown interest, and I know that issue is being right now reviewed. And I know Representative Collins wanted us to stay in touch with Gardner, and we're going to be doing that. We'll have a full report for you next month as to the status of the meeting yesterday, the results, and what some of the follow-up is. And then other things, careful consideration of how to best capitalize enhanced funding opportunities on cost allocation. I think you do that very well here. We talked a lot about 90-10 funding. I think you've taken advantage of a lot of your federal funding. However, I will say one thing though, and this isn't, I have not looked at the details of the advanced planning document, but you have to also be cognizant of the fact that 90-10 is going to go away at some point on the A87 waiver. I think the federal government has approved it up to this end of December 17th now. So if these states have been smart to figure this out early on, they apply for the 90-10 to get the eligibility Magi integration system going first. While they put in their advanced planning document, they put it in phases. Phase 2 is going to be SNAP and TANF. Phase 3 will be workforce and other related services. And they'll have a timeline projected. And I'm not sure, I haven't looked at the details of the APD that you have done here. But when you do that and you get that advanced planning document approved by the federal government, that locks in that 90-10 funding. When that 90-10 funding goes away, we go back down to 75-25 or 50-50. It's a great opportunity for states. That's why there's a lot of system improvement going on around the country. So it's important to find out what is in the APD, what do they have planned for any eligibility system enhancements. We talked about that enterprise hub idea connected to the eligibility system. It's a great idea. The problem is, if we talk about the idea, if you talk about the idea, and other things foreshadow that idea, because right now you're in a situation where you've got to fix the house first. you don't want to be waiting too long and you lose that opportunity on that 90-10. It's filing the details of an advanced planning document, getting the approval, and then you can begin planning for the actual implementation. So that's just an issue. We will continue to watch that closely for you because I want to make sure that your state takes advantage of as much as you can maximum funding sources.
Before we leave that, let me just, do you all have the ability, or do we need to have somebody from the department to basically give us a diagram of all the different systems we have right now, what the contracts, who the contractor is, what their responsibilities are, and what, if any, integration there are between the systems that we have currently?
I mean, that's a great question for DHS, and that's something that, I don't purposely leave it back, but I would ask that you ask them, because we could do it, it's just additional effort on our part. They already have all this. They can tell you exactly what their vision is and what the strategic alignment plan is, and when you ask the questions, we can help you to make sure that the right questions are asked in terms of the 90-10 funding, because, again, I just want to make sure that you are looking at the areas of the 90-10 that the department should be, and maybe they are. That's why I would ask them to give you a briefing.
I guess, do all of the things that we're talking about, the systems that we're talking about, fall under DHS, or are there some under workforce services? Or?
No, they don't all fall under DHS, and that's another issue here in your state. It's not unlike some states. Mississippi, for example, is very similar to your state. Medicaid and DHS in Mississippi are on different divisions, different departments. And their systems don't communicate in an interface eligibility framework like I mentioned. That's just a state example. But Mississippi does interface with workforce, because workforce and TANF are at DHS, and they're very closely aligned. Here, TANF and SNAP are now are at workforce. So one of the questions, I know that we were at workforce, Senator Bledsoe and others were there, we asked the question, do your systems talk or interface with DHS? Because the governor, obviously, and his task force is concerned about the workforce issue going forward. They have no current integration. We found that out, and that they're both working on their own systems. They have ideas and plans to get there, but because there's no real vision that's been accepted yet by the federal government, that's where you get the problem is they may come into you 2 years down the road and say, we want to integrate, and that could now be a 75-25 match, and that's a significant amount of dollars for the state. Versus today, a 90-10, as long as you lock in your planning and your vision, and you've got the people in the federal government approving the process going forward.
I guess, then, could we just ask you all to visit with the various departments and ask them to provide you with the information to create something like that? I think it would be helpful for us to see what we need to integrate here exactly.
We will do that.
Representative Ferguson, you're recognized.
Yes, when we went to InSpark, I thought they told us that because the federal grant had paid for the initial software development and the program development, that we could actually have that free to build our system on. Did I understand that correctly? And is that true of all these other states? Would we be able to take that program free and use it and build on it?
I mean, I don't know exactly what they were talking about in terms of what exactly would be at no cost. What wouldn't be at no cost is obviously once the plumbing, the work that integrate those systems. I think what they were saying was our planning, our modeling, our software, they would be willing to allow the state to use. And they work well with the state because it's a neighboring state. But I think where the InSpark model works effectively is having the data integrated into a data warehouse, where if the state has a requirement, or they need something, they need to produce a plan, they need to produce a report, that they're able to use the NSPARK model as a research activity, as a model to help further the waivers, the issues that your department sometimes struggles with because they don't have the data from workforce. And they all work together, but this is actually putting it all together in one source. And I think they were saying they're willing to share what they use and work with you in any way.
It's what Curum's doing in North Carolina. Is it a different program, a different structure than what we're doing?
That's different because that's an eligibility system. The NSPARK isn't an eligibility system. The NSPARK takes workforce data, takes Medicaid data, it takes data from human services, and it has a data warehouse that they can now produce a lot of reporting, a lot of information to health departments. And that's where it's integrated. And I think they'll explain more, but it's a really good model.
Okay, thank you.
Senator Sanders, do you remember your question? You're recognized.
Yes, thank you, Mr. Chair. It actually dealt with North Carolina and the Cure system there. One of the, and they are integrated, and essentially what they did in order to get to the point was it would be tantamount to taking a piece of plate glass and breaking it and putting it together in a stained glass form. They still cannot do change in life circumstances in North Carolina. They're having to do that by hand. If I understand that correctly. So there's, you know, that's been the real struggle for us. It's one thing to have the initial eligibility, but to go back and do redeterminations and look at change in circumstance. And that, you know, obviously got members. That means, you know, are you earning more? Are you earning less? You know, where do you fit in that income category? And I know this whole system. I was looking back at a calendar. I think my first meeting on EEF was over 2 years ago, when we began to struggle through this, and obviously it's still a problem. But I think it'd be very clear of not only what other states are doing, but what capabilities they have. And they may have a system. They say, well, we're doing this, but what you may find is that some of the things that they're having to pull out data code and run it in an Excel spreadsheet and literally go do things by hand. And the other thing that you have to look at is the ongoing maintenance cost that you have to maintain updates. Anytime you have sort of this customized system, you know, when the feds come down with some changes, you know, you're going to be out, as you know, you're going to be out a lot of programming time. So there are a lot of considerations to look at, and particularly with states that are sort of following the same path. In fact, we sort of followed their path. I think there's some lessons learned there, but did y'all look from, you know, she looked at or not?
Well, I mean, we asked the question about what systems are integrated.
Yeah.
And they are all working quite well. The question that you're raising is when there's changes that are needed to that system.
Well, I'm not talking about necessarily change. I'm talking about the key functionality of doing a change in life circumstance. That's one element. So there's two things. So that, and I understand it, that is currently not being done in North Carolina.
Yeah, and I don't know that answer, so I wrote that down. I want to double check that.
Secondly, to your point, what you brought up is, you know, when you have a custom, you can go with a COTS-based system, you can go with a customizable system, there's hybrids and all those things. You know, the thing is, when the feds come down the pike, or there's some rule change, or something that you have to change in your system, you're looking at, you know, potential financial exposure, you have to comply, or you'll get some waiver for some period of time. But eventually, you're going to have to come back and invest in programming. And I know that's one of the things that Director Myers at DIS has looked at, as well as our folks at DHS, in terms of, you know, what do we do moving forward. And the question is not in order to take what we have spent on Curum to date and sort of use those pieces and force, how much does that cost? Or do we start over and go with something else? I mean, you have to look at sort of the life cycle. What would be considered life cycle costs? Or what are you looking at annualized out over 1, 2, 3, 4, 5, 6 years, and from a capability standpoint? And I think that's one of the things we consider. I agree with you. I'm not sure that Gartner went far enough, but I think those are huge considerations as we move forward.
Yeah, I think, if I can just add to that, I think in our recommendation, a great example of what Senator Sanders is talking about, we thought that you should have a more automated system to look at changes in income. So So when you're able to see someone's income go up beyond that 10%, that creates an issue to redetermine and then send out the letter, you're waiting 1 year. So someone could change their circumstances and income month 2 into the private option alternative in month 2, and you're not going to catch that till month 12. And so what we had recommended is that you'd be able to do that in a more automated fashion, and that presents problems with those types of changes in direction. With a system that is not flexible, that can't do that type of interface quickly. And so we may recommend that, and that's why when we say, there are some things that we're going to look at our savings estimates to make sure if there's an EEF system issue that's going to hold back the timing on some of these savings, we've got to take that into consideration. That particular idea that I just threw out, that we recommended, will probably be put off for another few years. And if that's the case, you may say it's a good idea, we want to do it. You're going to be paying 75%, feds are 75%, you're going to be paying 25% on design, maybe some 90-10, but not full 90-10 like it is today. But if you have it all today put together, ready to go, the planning, you're going to have the benefit of that flexibility as a funding. But the system's not ready for it. That's the problem.
Okay, Senator, I'll let you recommend.
Thanks, Mr. Chair. My question is rooted in something I tried to look at and do a few years ago called the Common Client Database, especially regarding teenagers, particularly at risk. And I just had to drop the whole thing because you ran into too many privacy issues. And so that just prompts me to just think about, in this case, who has access to, I think it's a great idea, having everything integrated, but who actually has access? And are there any questions of privacy to be thought about here at all?
DHS has the eligibility system. They house the identities, the real client personal information, and then there's a unique identifier so that none of the personal information would be shared in other states that have these integrated systems. But DHS would house the data, and there are very strict rules on the release of that data to even state agencies.
Now, that's somebody at, say, workforce development, for example, could have just,
No,
it's strictly DHS.
they would match client identifiers, and that's
Yeah.
how they would identify, that's how these states identify if someone's on SNAP. An example of why this is so critically important is because it does have an impact on your benefits. And so, for example, someone that's getting SNAP benefits today in Arkansas and is also tomorrow collecting unemployment insurance, his or her SNAP benefits are supposed to go down in allocation. If that system is not communicating right away, knowing the unemployment amount, and able to then reduce the amount in an automated fashion, you're going to wait until you figure it out, and you're going to do what's called benefit recovery, pay and chase, which is what some of the states are starting to move away from. So that happens without getting all the details information from the DHS database.
Okay, and I'm fine with that whole concept. It's great. But even at DHS, would there be certain folks, individuals who would have access, and not just?
I mean, you
That
have
would
to ask.
depend on how we say, okay.
You'd have to ask DHS, but they're very strict.
Yeah, I think that's something. All right, thank you. Thanks, Mr. Chair.
Okay. But now we're at the 1332 waiver discussion. Stephen's going to handle this. There's been some recent guidance from the federal government. There's some states that have passed legislation on 1332, and we thought you should be aware of that.
Thank you very much. So I'm going to start with a little bit of an overview or a reminder of what the 1332 waivers are all about. You all heard about this from Dr. Chen back at one of the early task force meetings. And a lot of this content actually comes from his presentation, but I thought it was worth recapping just to make sure everybody remembers what this is about. So as one part of the Affordable Care Act, Congress passed Section 1332, which allows states to request waivers of certain ACA requirements, and also to propose alternative uses of the federal funds that would have been used for subsidizing certain enrollees. Just as a reminder there, under the broader ACA framework, people up to 138% FPL were going to be covered by the Medicaid expansion, and above that, up to about 400% FPL were able to receive several different types of subsidies to cover parts of the health insurance marketplace premiums on a sliding scale. That also included several other provisions that are waivable under the 1332 waiver, including the individual mandate, the employer mandate, the particular benefits and subsidies for marketplace plans, and the structure of marketplaces and requirements for qualified health plans. Several of the key provisions of the ACA are not eligible for waiver under 1332. That includes several of the insurance market reforms, including the prohibition on medical underwriting using pre-existing conditions, the rating bans, the use of guaranteed issue, and a number of other provisions. For a waiver to be considered by CMS and the Treasury Department, the coverage has to be as comprehensive as under the marketplace. It has to be as affordable, it has to cover at least as many people, and it must not increase the federal deficit. One side note here is that because there are a number of tax elements to the subsidy structure under the marketplace, that starts to involve the Treasury Department in addition to CMS, and so these waivers will likely require joint approval of both the Treasury and CMS as opposed to this 1115 waivers, which have just required CMS approval. One of the requirements of a 1332 waiver is that it has to be authorized by state legislation explicitly. That can be existing legislation or new legislation. As of December of 2015, there should be 5 states have enacted legislative measures related to 1332 waivers: Hawaii, Minnesota, Ohio, Rhode Island, and Texas. These statutes that were passed vary in how binding they are in their general nature. So last month, HHS and Treasury issued guidance on the 1332 waivers that went further than their previous regulations on the 1332 waivers. They narrowed the applicability of the 1332 waivers a little bit. In a number of places, they added a little bit more detail beyond that, which was in the regulations. But in most cases, it was not anything that would particularly change the strategic direction that the state might go with respect to 1332. One of the areas that could change the direction the state might go is the fact that the guidance precluded combining 1115 and 1332 waivers for budget neutrality purposes. The 1332 waivers are going to be judged independently of any 1115 waivers in a state, even though the agencies still encourage states to have coordinated waivers between the 1115 and 1332. Perhaps the most important piece of guidance, or perhaps the most important new change within this new guidance, was that the Treasury and CMS indicated that their systems would not be able to support modified requirements for things like the individual mandate and the employer mandate. While a state can, through 1332, request to waive the individual mandate and employer mandate entirely, and the IRS and CMS would be able to accommodate that. Changing, for example, the level of tax credits or the amount of the cost sharing reduction payments would not be something that they would accommodate. So in order to facilitate that, in order to make that happen, states need to be prepared to implement those sections on their own, through their own tax codes or their own state insurance exchanges. The next several slides go through the specifics of the state legislation that has been passed in support of 1332 waivers. I'm not going to go into detail on those, but I included that to give you all some specific ideas of how that might be done. An additional 6 states did have legislation filed along similar lines, including Arkansas, that have directed their agencies to pursue 1332 waivers. But for those 6, those pieces of legislation did not pass. And you'll note from looking through these examples that in only a couple of the cases is it really direct. It tends to be more authorizing it under certain circumstances. So with that, I'll wrap up the 1332 overview, and I'd be happy to take any questions.
So, kind of to summarize what the other states have done, again, it looks like they're just basically using the waiver to give permission to find ways to be more efficient, to have a task force and so on.
That's a pretty typical way that these are being built in.
And we did it without a waiver. I mean, is there any significant change to the, what they're asking with regard to the eligibility or the traditional Medicaid or the expansion population? Or is it just authority to investigate?
Well, in some cases, like Hawaii already had a version of an employer and individual mandate that was just different than what was passed in the Affordable Care Act. And so what they're asking for is to basically use the federal money that's coming down to subsidize individuals purchasing insurance on the marketplace to fund their existing insurance system with those FPL ranges.
Okay. What is the timeframe expected on to hear from any of these waivers, whether or not they're approved or not?
That's unknown at this point. The 1332 does not establish any strict requirements on the agencies to respond. The earliest that any of these waivers could potentially come into play is 2017. That's a statutory provision. Other than that, we don't have any, there has not yet been any experience with the agencies on how long they tend to take to process these waivers.
Okay. Any other questions regarding the 1332 waivers? Okay.
So the next is really just the last two slides here. Michigan's current expansion waiver was just accepted. They, the timeline's important because they were going to come to the end of their with non-private options, the Medicaid expansion program, and the governor was able to work out an arrangement with the federal government to extend that with some of the provisions. And some of them are still being worked on in legislation. In fact, you know, Representative Ferguson, you may be interested in this on the rewards, the type of healthy behaviors, initiatives, incentives aren't even worked out yet. So the state doesn't know what they are or what they're going to be, and there's going to be legislation, and that they don't have to have those incentives in place till 2018. So there's a lot of unknowns, but the beneficiaries here are going to be making monthly payments into the health savings account. And beneficiaries, from 100 to 138% will make monthly premiums to the health savings account not to exceed 2% of income. Now, that also indicates, again, so long as they are in the waiver approval, meeting healthy incentives and doing either a health risk assessment or healthy behaviors. That's actually how it's written into the waiver. But there's no description that I could find, and the description on the incentives for those healthy behaviors is all going to be pending legislative review and discussion going forward. So, but they did condition those payments. It's going to be up to 5% FPL, which is the maximum. But it could be down to 2%, so long as you meet these certain healthy behaviors. And that is only for the 100 to 138% FPL. And that was just recently approved by CMS. Failure to pay the premiums does not affect eligibility, enrollment, or access. There is no lockout in Michigan. So
what happens if they don't pay the premium?
if they don't pay the premium, they end up going into the maximum premium, but it would be more of a uncompensated type care situation. There is no responsibility or personal consequence.
So if they get sick, having paid the premium or not paid the premium, there's no difference?
They're not off the program, correct.
And the amount of the premium varies from 2% to 5%?
Yes. In the 100 to 138% FPL range. Below 100, very similar to what the governor's proposed here. It would start at 100 for the increase in food.
Okay.
Health plan covers all expenses up to an amount based on annual contribution. We talked about that. Beginning in April 2018, beneficiaries above 100% not medically frail must choose between the qualified health plan on the marketplace with premium assistance or the Healthy Michigan Medicaid coverage, which comes under their traditional managed care. Beginning April 2018, beneficiaries under Healthy Michigan must undergo a health risk assessment and meet healthy behavior requirements. And again, if they don't, then that maximum premium would apply. They did, by the way, Senator, they did ask for a 7% FPL maximum premium, and that was rejected by the federal government. So, federal government said you cannot go beyond, you can't go higher than a 5% FPL.
But did they ask to say there for a lockout or any kind of consequences for failure to pay premiums?
No, actually, I don't know the answer to that, whether they asked for the lockout. I will double check on that. And I don't believe they did.
So like, the third bullet there, must undergo health risk assessments. What if they don't?
If they don't, then they go from that 2% to the 5% of the maximum share, premium share.
But again, if they don't pay it, there's no harm, no foul.
No harm, no foul. There may be some other, something that happens, but I'll check. But there's no penalty, there's no lockout, there's no restrictive eligibility. Now, I'm going to try to go through this as quickly as possible, but this is moving on to the next item. Mr. Chairman, we're done on item D.
Okay, I remember we're going to item E now, behavioral health comes.
So Richard's going to help me out here. I'm going to try to go through the slides quickly. We've already been through this. This is a result of Representative Gray's question, which, again, I will reiterate, was a good question on her part to ask, because there are some areas that we found significant questions, I would say, that need to be asked. And I think the department agrees that they would like to look further into this. So I'm going to present now what our findings are. These are our final conclusion findings on those 4 theories. When we presented last December, or in December, we only had that first theory complete. So I'm going to go through this quickly, and if you have questions, let me know. And Richard and Dr. Oliver, who's done the analysis, actually met with the department yesterday, and we've had detailed discussion with the department, the Division of Behavioral Health Services. So we've assessed 4 theories of possible behavioral health cost issues. Our findings are 23% of the claims are multiples in a day, which amounts to about $40 million in a year. And we'll go through that as we go through this slide, and you'll get to see more of the details. Additional observations.
Before we leave that, multiples in a day,
Multiple claims.
and did you say that's a practice that's not allowed in some states?
It is allowed with proper utilization and proper review and management. It can be allowed,
Yeah, okay.
but nobody's managing it here as far as watching the amounts. Additional observations. Medicaid lacks the outcome metrics suitable for assessing the value. So we're talking here about value beneficiaries achieve through these added services. Services at the school decline, only 23% in the summer. So that's something that we saw just, again, this is in the data, we're reporting to you what we observed. Are providers over-treating in the school year, under-treating in the summer? What is the cost of education is keeping some of these schools open? Maybe it's a coding issue. Maybe it's not happening in the schools. It could be a coding issue. It's just not enough details right now for us to really figure out what that is. But it does present a question. Beneficiaries have a master treatment plan. Appears that no one's managing the provider services to achieve the outcomes. Again, this is really no difference from what we've been talking about in terms of an outcome managed system.
Okay, Senator Elliott, you got a question you recognize?
Thank you. On the over-treatment or under-treatment with the school, is it permissible or possible some of those students will be getting treatment at home in the summertime? Is that permissible?
Richard?
Under the codes that we researched, the answer is yes. However, the data that we found is coded to 03, which is the code for the school days, which is why I raised the question of, it raised several questions, as John mentioned. Are the schools open? Is there a cost there? Is it a miscoding? Or is it something else?
Okay. Thanks.
So the questions that Representative Gray wanted us to look at, well, one, the real overarching question was, what is their duplicate bill? So we divided out the 4 theories. First theory we're going to talk about right now, beneficiaries of rehabilitative day services. And just remember the number on the coding, so I'll show you that. Also have charges for other treatment on the same day. So the two issues. H2017 already includes some care, and the second is a beneficiary might not benefit for more than the hours of the day service. So this is in addition to the day service units. And that's the first thing we're going to look at. We'll get to the students in a minute. So the first thing is to let you know the codes that we looked at. So if you look at the bold highlighted versions here, these are the codes that we looked at in terms of the data. The $464 million is your behavioral health spend for 2014. That doesn't include, remember, the halo of the medical books. So when you look at what we looked at, intervention, mental health, paraprofessional services, this is the 2015. The 004 is behavioral health counseling and therapy. The 90853 is group outpatient. 2017 is rehabilitative day service. And 90847 is the family medical psychotherapy. So we, if you just keep going back, if you don't know the codes, this budget sheet will tell you what the codes are. The first hypothesis was rehabilitative day and other services on the same day. We looked at three codes for related services, and that was 2017, 2015, and 004. While providers might claim for other codes on the day, the services are not as closely related. So, for example, speech therapy, administrative drugs is not directly related, so we didn't think that it would be fair to include those. The assessment looks at the number of claims of all three types for a given beneficiary on a given day. Note that a more granular hypothesis could account for claims at the modifier level. We can talk about the modifier level, and there's been some discussion yesterday, and Richie can talk about that. But that's not within the scope of our analysis. So looking at the description of the codes, we thought this would be important. This really gives you an identification right from the manual, how the codes are described. So if you want to know what the counseling and therapy is, the description of face-to-face treatment provided by a licensed mental health professional on an individual basis. And then you look at 2015. So these are very similar services. We've given you the limits in the manual and the outcome in the expected outcome on the right-hand column. And again, a lot of this you can review on your own. I'm going to go through as quickly as possible. The method, we created a table of beneficiaries, columns, and days of the year, and rows in each cell. I mean, the bottom line here is, I think this is Dr. Oliver telling you he looked at 23 million claims, and it was pretty significant analysis. So, 46,000 beneficiaries claim some level of service for one or more of these three codes during the year. Thus, there were 17 million days of claims. So he looked at the claim days, but there were 2.3 million days on which claims were made. And on average, providers are claiming services for each beneficiary about once every 2 weeks. In total, providers claim 2.4 million claims for these three codes. And that amounts to not as significant as other claims, but they're pretty significant if you look at the total number for those three areas. Not the whole 464 million, but it's a pretty significant amount. And I think it's significant because that's the area where Representative or others probably have heard there's some concerns about billing patterns. But here you start to look at what our findings are. Multiple same-day claims are made. So let's look at code H004. And that's the code Behavioral Health Counseling and Therapy. So 7% of the time, when that code is claimed, multiple same-day claims are made for that code. So it's not just one claim in for behavioral therapy. There's 2 or more claims, as you can see. So, and I don't know why that cell range looks like that on the PowerPoint slide, but the bottom line here is the majority of these claims are 1 per day, and only 7% are multiple. But again, it proves the point that there are multiple claims in one day.
What is that? Explain to me practically how that would happen.
From what we understand, the possibility of this happening. I'm a little unclear on HL04 because I believe that this can be delivered both in school and out of school. But what we understand in practice is that the child, this is taking place on non-school time during the day, from what we've been told. The child might be in this benefit for 15 minutes, half hour, an hour, although that's probably extending in terms of the day. And then the hours in the day that the child is at school. Then they would go to another service provider that's in school, or theoretically group, or rehabilitative services, or interventions, which is 2015. And we'll talk about the 2015 because the interventions raises other questions. But hospital houses, and there is some potential expedience in terms of the child being there and not having to be transported. And also want to emphasize that all these services are submitted to the ASO Beacons and under current rule, including medical necessity rule, and the current rules for the benefit themselves, they are allowed if the medical necessity threshold is met. There's also no acuity framework in this because of the lack of an independent assessment that would indicate acuity levels.
Is this outline of what you would see in other states?
No.
Again, there could be issues that we're going to need programmatic folks to start to look at that require more in-depth analysis because there are claims being billed, the same claim, same day, multiple times. This is multiple same-day claims for intervention, which is another service, 2015.
Okay, before you press into that, Representative Ferguson, you're recognized for a question.
Yes, you mentioned it's medical necessity. Does Arkansas have a different standard for medical necessity than other states?
All states have their own medical necessity definition, but I would say that Arkansas's definition is almost first generation. In the states have become very specific in the way they interpret medical necessity. If you went to the state of Washington, there are several levels to the medical necessity determination. Some are real clear. You've got, you need heart surgery, you need heart surgery. The authorization is another issue. But for this particular benefit, the construction of medical necessity in this state, which is basically a presumptive favor to the prescribing practitioner, who in this case would be an RSPMI provider that submits their information to that Beacon Value Options. Beacon Value Options has to go under the current medical necessity, which is the practitioner's favorable interpretation. In other words, it's biased towards the initial determination and makes the process of a third party like Beacons questioning that extremely burdensome in the rules about how they have to re-inform the practitioner about questions and what kind of time period that has in relationship to what the child's current status might be. The process looks like it would take 30 to 45 days.
I would like to add to that, if I can, Representative, what I found in the discussions we've been meeting with providers and folks, I think what I saw being unusual here is your rule process. That you have a Medicaid Fairness Act that requires that any time this manual is changed to even reflect evidence-based practices, that there needs to be rule changes accepted by the legislature, approved by the legislature. I'm not sure I've seen something like that in other states, but because there are rule processes. But when we spoke to the vendor that does this type of utilization review, and they're using a 1970s manual and not adopting evidence-based practices, and you look at the fact that the rule hasn't been changed because the department can't get the rule passed even on evidence-based practices, that becomes an issue. And I'm only raising that because your question, I think, is on point with what we've heard in the field.
should still be on. Okay, let me push the yellow button again.
Okay. And that, I guess that was my question. It's been my understanding that because of the Medicaid Fairness Act, that it's almost impossible to deny anything. You know, that it would always be changed. And I'm not sure how we would get around that. How would we correct that?
Well, that's a great question, and I do think it's extraordinarily difficult under the circumstances for, in this case, the behavioral health, or any other one you bring into the state, frankly. I think this is a bigger issue. I think John has alluded to that in past meetings. If you bring managed care under the current circumstances, it would be interesting to see if managed care companies would actually respond, let alone ASO companies who know about this experience. But nevertheless, the way to look at changing your medical necessity, if you want to do it quickly, is determine what your principles that you want to bring into it, and have, someone look around for state models here, because medical necessity has been invested in states quite a bit over the past several years, and states change them fairly regularly. The larger states, regularly in terms of 5 years, 6 years, certainly not 20, 30 years.
But it's your opinion we'd have to do that in statute before we could proceed with managed care provider health?
John's the attorney, but our understanding now, yes, right now, we're changing statute so you give a certain amount of administrative authority to your administrative entity. There's always, CMS requires a public process, public hearings. There are ways to stop this if you're a naysayer, but certainly not going through the legislature to get administrative rules passed.
You're not changing the grievance process. It's required by federal law. I think you got good parameters and restrictions around making sure you don't, you have to have due process. You have to make sure you meet those conditions. But what you have is antiquated rules with regard to utilization standards and evidence-based practice being reviewed. So a physician's word may not be able to be reviewed here. And maybe that's why we saw in the field when we did our original analysis for you, I think it was a 5%, somewhere very low.
Right, it was very low. At the time, I remember saying to you, we thought that was extraordinarily low, and in fairness to the vendor, we were not as aware today then as we are now about the mechanics of the actual detail that they need to bring to bear when they actually review a case. It's one thing for us to talk about the aggregate system, which we did at the time, but that's one of the reasons why, probably the priority reason why you're seeing a 5% denial rate in a benefits package, if you will. Most states would be looking between 15 and 20% denial. Doesn't mean the person will never get services. It may mean that the case needs to be reprocessed or reassessed or denied.
Okay, before we leave this, John, seated back there, how long have you been at DHS?
As director, 10 years.
I guess, would you come back, 'cause I think you raised a question that we keep dancing around the edges of, we need to get a little clarity on, and that is, in Arkansas, the ability to implement rule changes, has it really been thwarted as much as we're hearing here in your ability to bring change to the Medicaid system? And I guess while he's getting there, John, this Medicaid Fairness Act we're talking about, is that state or federal?
It's adopting the Federal Administrative Procedures Act, basically, but it's very specific to your state. You've added a lot of restrictions, some good, some really good, but we're particularly talking about one area.
Because as you all know, we changed our constitution now, where now it's even more, there's more teeth to the review process, that a rule cannot go into effect. And I guess what I'd ask you, John, is comment, is that an impediment to us making changes because of the influence or whatever on our political process to get the rules changed?
Yes, I think it is. It has been, when we talk with colleagues around the country, one, it's just a very cumbersome process to bring every little change in Medicaid has come over. Some cases it overwhelms committees with all the small stuff we bring. But it just creates a huge opportunity if we're trying to make a significant change in a program, and there could be 100 pieces of that change on that package. That's 100 opportunities for some stakeholder group to say, we don't like that, and so we think that should be, could you hold that up till the next committee? And each of those changes actually goes through at least 3 committees. It goes to Public Health and Rules and Regs and Lake Council, in some cases gets referred somewhere else. It is a very burdensome process for us to make changes, and we've often found that when we try something significant, it looks like we're only going to do some small pieces of it through, and so we back off. So I do think it would be helpful if we find some way to make it a more streamlined process that still give you all the input you clearly need. And I would say the Medicaid Fairness Act, again, our Medicaid experts and attorneys could give you more details, but we're not aware of anything like it elsewhere in the country, and it has made it very difficult for us to really go after situations where we think there are problems, because it just places a huge burden on us, burden proof on us beyond what other states, way beyond what other states said they had in terms of being able to do recruitments and really make sure this program integrity.
So you're saying Arkansas is one of the most difficult to make reforms because of the process we have for the root change?
Yes, sir, and that's based on what I hear from people around the country also, including, I think, Stephen Group here from what they say.
You would agree?
I mean, as far as the Medicaid Fairness Act, this is one area that I absolutely agree. And it's going to be a real problem if you don't change that particular area to get any savings out of behavioral health.
Okay, legislators, you heard the problem there, and we're going to have to decide whether we're going to fix it or not. We're being told that we are a problem on changing the system. Senator Sanders, you ready?
Thank you, Mr. Chair. I would just point out to members, we actually had a rewrite of the Medicaid Fairness Act and our False Claims Act last year. It was actually shut down by a lot of the people that you see in the audience that didn't like it very much. And in fact, I went to several meetings and they told me how awful it was. You know, how could we even push for that? But the fact of the matter is, we looked at this when we were setting up the Office of Medicaid Inspector General, and the high thresholds that we have. I mean, we have a higher threshold for recoupment than the federal government has. In fact, many instances, the feds come in and recoup. We can't recoup to repay the feds. I mean, it's very difficult. But I would encourage you to. I'll get those bills to fill. I worked with folks who were in program integrity around the country, looking at our Medicaid Fairness Act. And it's not to say that it is all bad. I mean, but there are some very specific parts that really hamstring the state in doing an effective job. I mean, my question is this, gentlemen. I mean, so we're working off of a 1970s manual. Has the medical science on behavioral health changed since the 1970s?
Yes, sir.
Okay, and so my question is, in terms of the threshold for medical necessity, earlier before lunch we heard that we've had a 95% reduction in the usage of psychotropic drugs. So were those drugs prescribed on the basis of medical necessity? I think they were. I mean, I think that's it. So I think what we're seeing here, and those of us who've looked at behavioral health in this state, I mean, it's pretty wide, you know, in terms of being able to compartmentalize and put people, kids. Man, you look at the roles. I mean, you look at the number of kids that we have in our RSPMI program. It's big, but I'll send that out to you. Hopefully we can look at that. But this is I'm really curious and interested in sort of the H2015, that intervention through paraprofessionals. In terms of, it would be nice to see if we could see a sort of a corresponding rate in CPT code next to those in terms of the payout.
There's more that I want to go over that. I think you may see later on.
Okay.
Not too much, I tried to put it into some type of,
Well, I think what would benefit us truly, I mean, so if we're going to get to a place where we actually get our Medicaid program into the 21st century and out of the times of bell bottoms the first time and you know, those flop haircuts and God forbid disco, that we need to, I mean, we really need to look at sort of the structural anomalies that exist here as compared to our friends, it was rough. But I think we need to bring it into the 21st century, and I think that can't be. I mean, it's not so much. And then I think we need to look at the benefit. I mean, we really need to look at benefit design, because ultimately what we want to do is benefit our people, and particularly those who are at higher risk. And then the overall lack of an independent assessment is very troubling. I really appreciate the work. This is very comprehensive. I appreciate it very
appreciate Representative Gray asking the question. I mean, it's an area that's important to look at, so.
And can you have one of your legal experts look at the constraints that we have because of this constitutional limit in Arkansas state law and Arkansas Medicaid,
Yes.
whatever it is, and bring us
Mr. Chair.
and maybe with John, how do we fix it without amending the Constitution?
It's honestly, my sense is the constitutional piece is not a problem. I mean, I think it gives you the authority to do approval, right? But it doesn't require that you
Yeah,
look
just
at
have
every
everyone
piece of
sort that
detail.
out.
I'm not sure that's, I mean, I think you could argue whether it's a good amendment or not, but I think there's lots of stuff we could do even with that in place.
Yeah.
Or you could do.
I guess that's what I need is, you say the other states are more streamlined and more, and your colleagues have told you that it's much easier to bring evidence-based changes and so on to the table. What do we need to do to fix in our code that will help us get there? Senator Elliott, you recognize?
Thank you, Mr. Chair. That last question you asked was one of my questions, and as I really was just wondering out loud, I'm wondering to myself, if the constitutional amendment is going to hamper us. And, but at any rate, we're going to get some information about that. But one other thing I think would be beneficial, at least for me, even as a non-member, I wore bell bottoms with many colors, and I was a disco queen, so I think about that. And so just historically, while that is a very antiquated, maybe policy connected to that time, it seems it would be useful just to understand why it was in place and why it's that cumbersome to start with, just so we have a point of reference. I want to, err on the side of everybody was not just crazy, although it seems kind of bothersome to me now, frankly. But I think a little bit of understanding that will be helpful to us as well and informative, Mr. Chair. Thank you.
Okay.
Thank you, Senator Elliott.
So we'll continue on. The 2015 is your intervention mental health paraprofessional activity. Again, there's still 3.7% of the time, and then the 2017 day service, 1% of the time. These are claims for the same service on the same day. So there is a potential for reducing same code. Now I highlight this, same code on the same day. So there's not as much an abuse there or an issue, but there is some potential for eliminating that, and we did try to quantify it for you. So the question is, what are the valid clinical reasons that a beneficiary requires the same clinical intervention more than once per day? I mean, somebody's got to ask that question, and that we're not the experts, nor are you. That's something the department needs to work with us on and try to identify for you. So that's one question here. There is an opportunity, $9 million opportunity already accounted for in the overall population, but you can look at that $9 million opportunity if you just eliminate same code, same service in the same day. Maybe that's not a good idea, but yet it is an opportunity. Now, this is an interesting one. So 23% of the beneficiaries claim multiples of the 3 codes on the same day. So now you're getting into multiple claims for similar services same day. So looking across all 3 codes, multiple claims are frequent. When there's a claim, 19.5% of the time, there's a second claim that day. 2.9% of the time, there's a third claim. And these aren't the same claims, but these are those claims that we mentioned that are connected. So, again, that prompts a question on our part. So, theory 1, we feel it's substantiated. Beneficiaries are claiming for rehabilitative day service, intervention mental health professional, and behavioral health counseling and therapy. And then the question, does the beneficiary truly benefit from more than one service? In addition, beneficiaries are claiming for the same service we talked about, but that's a smaller problem, but we don't suggest there's never a clinical reason. I'm going to underscore that. We're not suggesting that these are conclusive findings, that the services aren't needed. This is the data. This is the claims history. We're trying to paint a picture that there is an issue that needs to be looked at. So the cost of multiple services of a day, We looked at, there's 547,000 claims, are multiple in a day. You know, if there are 3 claims in a day, for the above codes, this would represent 2 multiple in a day claims. So basically, you look at your amount on average, we took the weighted average of those claims, and you're talking about $40 million there in multiple claims that could potentially be eliminated if you had some rule changes.
But again, you don't know how many of those are
No.
combined because of transportation, it makes more sense, or how many of them are bundling because, well, we got in there, let's do this and this and this.
No, and without further digging, Senator, we wouldn't know that.
Are there any states who, though, have said, we're just not gonna allow multiple claims in a day?
There are states that will not allow multiple claims for certain identified services on the same day. This has been a big issue in public mental health, Medicaid mental health for years. CMS had some pretty strict boundaries between having more than one service delivered in a day. And for people with serious and persistent mental illness who are in a clinic, they'd see the psychiatrist for the medication review or the psychiatric nurse and are going to day programming. It didn't make much sense at that barrier either. But generally speaking, school-based services is what I think really should be a concern on multiple claims, as well as people in the community. But the school-based aspect of it, I think, is something that CMS has paid a lot of attention to. And about 5 or 6 years ago, there was a national audit in several states had to pay back substantial millions of dollars in Medicaid services delivered in school settings because they didn't meet the federal criteria in the day.
Senator Sanders, your reference?
On that, Richard, I mean, so the Department of Education and HHS just issued a joint bulletin that goes to the very heart of this issue. So, and I know we've had, I can think back to a number of, for really going back to 2012 and 13, this is sort of when the interest in RSPMI started, that we had a number of schools that are using the school-based services, and I think one of the things that DOE and HHS is concerned about, and Senator Elliott, this really kind of bends around kind of some of the things that you've been working on. I mean, are we seeing instances of kids who have IEPs who are, I've heard from a lot of school districts. In fact, former Representative, current U.S. Representative Bruce Westerman's wife has worked as a guidance counselor and talked about some of the problems or a counselor, sorry, for these types of therapies. Where there are some real problems. I think we had some workflow violations that providers were looking at, were given sort of free access to look at student records to figure out who might get their services. And then I heard from some other school districts where there were, you had kids that were being treated by Medicaid mental health providers that should be treated in just a purely special education setting. Have y'all seen anything like that?
Senator, I think this question about children with an IEP in relationship to this data we've discussed briefly as a team, although it was beyond our scope, and I think we even discussed it, from another perspective, we would want to know children with an IEP who are receiving school-based services if they go by Medicaid, just to make sure that it was appropriate use of Medicaid funding in a school-based setting for an education federally required plan that is benefiting the right to children with special ed needs. We've raised the question amongst ourselves as a team, at least theoretically, that clearly the group therapy service or the rehabilitation as a group methodology is undoubtedly not in the classroom setting, but it did raise the question of the intervention in 2015, whether or not these particular RSPMI providers were actually attending class with the child in order to potentially help them stay on focus and be able to be absorbed and keep their behavior in check if that was an issue in the classroom. But we didn't pursue it because it's beyond the scope. But I do think it's a serious
Could that not, just as this was an issue some years ago, could that not potentially put the state at risk for a lot of money if in fact we're misapplying Medicaid dollars in the wrong application?
Well, the answer to that is always yes. I think in the IEP, the Medicaid area, the risk is, probably a little more accented because CMS has looked about this and continues to look at around the country about this particular issue because it is a federal, barrier between federal education funding and Medicaid funding and anticipation on that benefit. That entitlement to an IEP under a school setting has different standards, being education is constitutionally required, and Medicaid is not. It does put states at big risk.
Representative Sullivan, you recognize.
Thank you, Mr. Chair. If the services are prior authorized and there's a cap or a limit on how many of those services are available, then what is the impact on the total utilization if they're given, 2 or 3 are given in the same day? The total utilization remains the same if they're capped via prior authorization. Is that not correct?
If I understand your question correctly, that if the ASO here pre-authorizes services to say 10 units of service under the construction of multi-claims days, then under your current rules, the answer would be yes. But that would be a period at the end of that sentence because it doesn't answer any of the fundamental questions of how the system got developed to allow that kind of a construction, lacking in the acuity level and having a school-based service that doesn't appear to be very clearly defined. I might add to the group, 2017, the rehabilitation service is, quote, an array of services. There's to help the child function, etc. But in today's day and age, states don't pay for Medicaid behavioral health and array as being the definition of services. There are specific expectations of what should be in the child's day rehabilitation program, and they're not in there.
Sure, follow up, Mr. Chair. Yes, and I agree with you, but doesn't it change the question that we're asking to the last point you made versus the utilization point? I mean, are we going to spend our time and money and energy actually looking at the value of the service provided, or are we going to count the numbers of the units? While there's value in both, I would assume or suggest that a child receiving multiple services in the same day, maybe crisis intervention and maybe a group session, if we spend our time saying is that valuable versus looking at the actual services provided and the benefit to the patient, would seem to be the best utilization of our time.
I don't quite understand the question, but I would agree with you that both are valuable. To the extent that us looking at the data, we were asking you that has raised some of these questions. That has led us to the issues of your medical necessity and the Medicaid Fairness Act. That has led to the question of what is the relationship to education constructions if the child is in that status of being a student at the time those services are delivered as opposed to being in a clinician's office or a paraprofessional's office. What I'm understanding and what you're connecting is what's an implied question of what's the solution to make sure that those children have benefits. And we do get to that later on in the presentation if I'm on base. Thank you, sir.
Sarah Elliott, recognize.
I have a specific question about, maybe to understand something I'm not familiar with, on counseling and therapy, where I'm looking back at page 6 where it says a maximum of 4 15-minute units per day. So does that mean that if I'm a counselor and I come in to counsel a student, I get 15 minutes with them, that's one billing? And then later if I do another 15 minutes, that's another billing? And also, why is it a max of 15 minutes, if you have an idea?
Well, The unit is set up in order for the codes to trigger a payment. So the payment would be in relationship to the amount of time that's in the unit. That is opposed to potentially a day unit, which might be defined as 6 hours. It's not in this case. So I think the application of units during a day would be in relationship to what the authorization has been for the delivery of that service. So I don't know if I don't think I'm answering your question.
No, I'm trying to figure out if I'm a counselor and you are my client, do I get 15 minutes with you and that's it? And then is that where I get paid after the 15 minutes? And then,
That's a good question, and I don't think I can honestly answer that. I would think that under the construction of the benefit and the prior authorization, that if the child was in crisis and you only have 15 minutes scheduled for that day, the clinician could stay with the child and try to help deal with that crisis situation and bill for it. But that would get back to the details of what the authorization coming from the ASO would be to the vendor and how they're managing.
if that is the case, and just thinking back to teaching days, I can see where there may be as many as 4 billings a day if I'm interpreting this the correct way, and I don't know, somebody would have to tell me, because that's not, oh, okay. Because I can think of a student, 15 minutes just would not do.
Okay, Representative Ferrari, go ahead.
Okay, but help me out.
The 15 minutes of billing, that you
Okay.
that council makes 45,
Yeah,
any bill.
okay.
So that's how the Medicaid
Would you
reimbursement.
please put your, mic, if you don't mind, I'm not sure I need to read.
Pull your mic there closer.
Oh, okay.
You're a shy guy.
That's all right, I like you. It's the 15 minutes of billing unit, that the counselor could stay with that student for 45 and bill 3. So they're not getting 15 minutes with that student, they're actually getting paid, they bill in 15-minute increments.
Yeah, but that's why I'm not understanding, that's why I can understand clearly how that could happen. If the counselor stays with the student for 45 minutes, is that one billing or 3 billing?
That's 3 units.
3
One
units.
bill.
But 3 units.
Right, 3
Okay.
units of.
So a unit and a bill is, those two things are different, those are not the same thing.
The unit, I think what the Stevens Group is telling you, they're getting 3 units of 2015 and one across the hall, and we're getting 3 more units,
Which is one claim.
which is one claim.
Okay,
But,
all right.
but the 15 minutes that you're seeing is actually a unit that's billed. And you bill by time. You bill by time.
I'm gonna ponder this because I think I understand it, but I'm gonna go study it and make sure I do.
But
Thank you for that. That does help,
I
thank
can
you so
help
much, yeah. Thanks, Mr. Chair.
Let me just add to that. So when you say that you have multiple billings, are you talking about multiple codes? But we're not saying that somebody billing 45 minutes, 3 units is a multiple billing, are we?
No, if you go up to the limits, a maximum of 4 15-minute units for HO4, that's on slide 6.
Okay, so on page 15 now, where we're at, and
Go-
we're talking about,
Go to,
yeah, slide 15.
okay,
And we're saying it could be up to $40 million because of these 3 codes being multiple billed, or at least 2 of the 3, right? If there were no multiple billing allowed. I guess what I'm saying is, if there were no multiple billing allowed, you could still have an hour and a half of 8004 or an hour and a half of 802015, but not 30 minutes of each.
that's correct.
And I guess the question is what we're trying to get to, saying what we think may be happening in some cases, or people are spending an hour with a kid and billing twice.
Potentially.
And I guess.
And they have up to, in that first code, they have 4 15-minute units. to
Because
bill
they can
for one
say
claim.
8004 and 82015, as I read the expected outcome, they're not very different.
No,
So a person could say, well, I did both of those in the same time, so I'm going to bill Medicaid for both.
potentially.
And again, we're not saying that's happening, but that's potentially why there are sometimes rules put in place to prevent it from happening.
Correct.
So I guess where, right to get right down to it is, I think what we need, we don't really have any idea out of this $40 million, whether 1 million of it is fraudulently billed or 20 million is fraud. We don't know. But we know that some states are concerned enough, they put in place some rules and some procedures to prevent that type of thing from happening. And I guess that's what I would like you to bring us is kind of like with the rules and regulations, how do we fix and how do we do that without impeding kids getting the service that they need to get? And it's not, nobody's trying to say that if a kid needs 2 hours worth of service of 2 different things, we prevent that. But what we're trying to say is what we don't want is a kid getting an hour worth of service and the state getting billed for 2.
Yes, and we're gonna do that. We're gonna hopefully work with the department. There's some recommendations we have here, and maybe if you can hold that, Mr. Chair,
Sure.
till we get the recommendations.
Absolutely.
Because at the end of the day, we wanna make sure that when we come back in February with savings estimates for you, that we're trying to make sure we improve the quality of services and we don't impact the quality of services. So what this is doing here is really the data we looked at gave us an understanding that this does present a potential issue to look at for the question that you just asked, because it is something nobody has been looking at. And it's one that we definitely need to, and we're coming to an understanding of why.
Okay. Senator Sanders, you're recognized for the question.
Mr. Chair, and I appreciate what you're outlining there. I think, I mean, there's some really key issues here to look at. And I want to be careful to jump out and hit the fraud button. You know, that's the F word that we always like to use as politicians to describe this. But I think a lot of what we're looking at is sort of an overly broad policy that has, I mean, you know, I'm emphasizing here just like you guys have. So we have a very broad policy that we know that the only determination made is medical necessity that was based back when Senator Elliott was a dancing queen, and she still is. And I mean that from my heart. So my question is, Elizabeth Smith is here, she's Inspector General. Again, I want to be very careful, and again, I don't know if this, I think it would behoove us for you, and again, because we're talking legislative branch, executive branch, to share what you have found with her, not so that, again, Inspector General isn't just to go after fraud, but in her enabling statute, she has the ability to make policy changes, not just recommend policy changes. She has that ability too, but she can actually make policy changes so that it might actually expedite some of this. And I think there's some things, I've kind of flipped back to see what some of the things that you're saying. I think she can be an assistant. I don't want to speak for her. Elizabeth, you're in the back of the room. Mr. Chair, could she come up?
Yeah, she's on the agenda here in a bit, but you're welcome to come on up and address this. Elizabeth, where are you? Yeah, come on down since Senator Sanders wants to, read you your rights.
I apologize if I got us out of order here, but Ms. Smith, I mean, obviously.
Go ahead and state who you are, director, and you're recognized.
Hello, my name is Elizabeth Smith.
And I don't know if you heard what I said fully back there, or if I adequately explained what I was driving at. But is this not, I would be very interested that you take your office, take a look at what they found, because I think what ultimately we're going to get to is some policy change. And I would be interested in your office taking a look at, I'm sure you have looked at behavioral health providers, in sort of the normal run and work of program integrity. But is that something that you would be willing to look at and take this information and maybe come back to us in February?
Yes.
Or maybe give us some idea of what you could see to make some determinations of, are we looking at situations where students are sitting in group therapy, but that we're being billed for individual therapy, or as the chair outlined, sort of, the potential there? Is that something you could look at?
It is, and it is something that we are looking at.
Okay. Well, you cool with that, Mr. Chair?
I am awesome with that.
Great.
Okay, you can.
Thank you.
I think you're away, so if you want to relax, you can.
Okay.
Representative Sullivan, you're recognized for a question. Should be.
Thank you.
Okay, push the yellow button again.
Okay, there we go. Just to bring a little clarity to Senator Flowers, the question you asked, you know, a typical billing in a day might be if a child came in first thing in the morning, and the therapist knew that the child had had some significant issues the night before. And the child may step in, meet with the therapist for 15 or 20 minutes. The therapist then bills for that. They may have a group session or something like that later on in the day. More than likely, they're going to have an individual or a group would be a reason they would bill twice in the day. And then the therapist may then visit with the teacher and ask the teacher, how's the student doing? So that's a typical case of 3 billings in one day. Now, are there opportunities for fraud? Absolutely, as there are in everything that we bill. This kind of gets to my point about, are we checking on how many times we're billing 3 codes in a day, or are we going to check on the impact the service is given?
Well, again, there's so many questions here, so you really haven't seen the flavor of our recommendations, because everyone's jumping, I could go right to the recommendations. It's really a lot of everything you asked for.
And I appreciate that. And again, my point was to Senator Flowers and asking, why are people billing 3 times in a day? Well, that's typical.
Yep.
That's the life in a school for kids with significant mental health disabilities. And I appreciate, you know, there certainly is inappropriate billing going on, and there's better ways to utilize that. And I appreciate the opportunity to examine those. Thank you. Thank you, Mr. Chair.
Surgeon General Bledsoe.
Yeah, thanks very much. Just so I can get my mind around this, I want to make sure that I'm understanding this correctly. So we've talked about if we have 1 child and 1 counselor, but if there's a group and there's, say, 10 or 15 or 20 children in a group and there's a counselor interacting with them, does that bill go to the state as, we'll say it's an hour that they're interacting, as 1 hour of bill time, or as, let's say if there's 20 students, 20 hours of bill time? And have you seen cases where maybe there's been some discrepancy there, and how those things are actually defined?
Again, we have not seen that, because the data doesn't really tell us that deep level of analysis. But I can tell you that in our interviews, in the field work we did, that in fact has been happening, or there's a fear that that has happened in some cases, and there's currently a review for that particular activity.
But if there's 20 students and 1 counselor, and they're all interacting for a single hour, that should be billed as 1 hour, correct?
It should, but I don't know if the manual would prohibit it being billed for 20, so that's the point here. And I think that that's a question that probably be better asked of the department, or even the OMIG.
Thank you very much.
And again, I just want to make sure, you know, we haven't used that F word. And I want you to know that we were asked to look at the data, and that's what we're reporting. And I think it's opening our eyes, and that there needs to be further review. The other area here, the 2 other areas were students receiving at-school treatment, which is what I believe the representative mentioned, for certain codes, and may they be claiming for other care. Students that are not receiving the H2015 care might be receiving more care than is reasonable. Those are other 2 options and theories that we looked at. Again, those are theories. So we looked at these other codes, and again, these codes are in group therapy, 90853, 90847, and you can look at, once you add these codes, this is more school-based, all traditionally the school-based, and then you see the claim analysis. 816,000 claims for all 5 codes at school, total $64.6 million. And then you get an array, you can get an understanding of the exact amount total for each of those claims at school. Most students are averaging fewer than 3 claims per month. This tells you, or tells us, looking at the data, that there are a lot of students out there that are not getting a lot of claims. Maybe that's the other end, that there are other claims or other services that they're not getting. But there are a significant amount of students that are getting fewer than 3 claims a month. That's pretty significant, we thought. We found 6,300 claims for the same service on the same day at school. Now, these are the school-based claims, and you can see the type of claims are listed on the bottom. And again, our only question here is, can that be supported by clinical outcomes? And that's, I think, one of the questions that was asked. Yeah. So, 15% of these school-based claims on the same day for all 5 services. Multiple claims, actually, on the same day. For all 5 services, it came up to 15%. This tells you the average claim amount. The average claim amount is somewhere around the $71, $75 range. I don't know the exact amount. I thought we had it in there. I think it's about $75. Impact, estimating the impact, you know, the effect of these school-based multiple claims, again, we tried to quantify it. And I want to really get to the recommendations. Theories 2 and 3 are not directly supported, but we highlighted it as an opportunity. The theory that students get more than 6 hours of service is not supported. The average amount claimed for days when there's a claim is $93 across all 5 services. But we found 6,300 instances of more than one claim for the same service on a day. And, you know, that's a small opportunity, but that's, I would just say number 2 and 3 theories are not supported by the evidence we saw in the data. But the summer issue is one that's real. And so the question becomes, is that a coding error? Is that a potential issue with regard to do they need the treatment during the summer? Are they opening the school?
I'm having trouble keeping up here. I'm having trouble reconciling the 2 numbers. So initially, we talked about $40 million was the potential in multiple claims. And then this page has 123,000 times 79 is 9.8 million.
These are school-based. These are the school-based. The other one where you're it could be school and adult, it's a rehabilitative day and group counseling and individual. This is just 2 and 3 focuses on school-based services. So, for all 5 codes, during the summer, there was a decrease of 23% during the summer. So then we look at all claims by month during the summer, and you can see what happens during the claims in the summer months. They do go down, but 23% decrease. And the question then becomes, 70 some odd percent during the summer, is that, again, clinically appropriate? Are schools open to host behavioral health services? Are students attending summer school? What's the nature of the need being filled? Does this change in the summer? Are providers failing to provide adequate services? Then in the summer, it goes down in the summer, or something else happening during the summer period? Should be looked at. That's something we feel, again, the department should continue to look at. Theory 4 was disproved, but it raises that whole issue about in the summer, providers are still claiming 77% as many services at school when the schools are largely not open. So is that clinically effective? So, before we get to that, I want to get to some of the recommendations. I think, so in looking at slide 33, I think if you look at these other services, you're talking about another $158 million. So the question then comes down to, how can Medicaid know that these services are managed for outcomes? And this gets back to the question on value and outcomes, and it gets to the whole idea of management entity that can look at the delivery and the efficacy and the evidence-based nature of these services going forward, to make sure they're appropriate and making sure you have evidence-based rules in place. So these are let me just get to the recommendations, because I know Richard is going to talk about the recommendations. So we leave you with, you have a lot of information here, but we really have about 4 recommendations of action. And it goes in line with Senator Sanders wants us to work with OMIG. We believe strongly that's a good outcome here. We continue to drill down and look at, look at these policies going forward. 38 is where I want to just focus on, and Richard, I'll hand it off to you. But we really looked at this issue, and it's something that you need to start making some decisions on.
Thank you, John. The recommendations are structured on what we consider that could be moved on in an immediate basis and what we call a near-term basis. The immediate basis are more specific to the data and concerns that were raised throughout the presentation and the questions as well. The first one is to create a new policy requiring advance approval for more than one of the following in a given day, and those are the codes, the 5 codes that were looked at as appropriate. We think that this type of approval should be done in advance, and that the approval of multiple service days should be known by the vendor when they're reviewing the claims and the pre-authorization requests. And we're not clear that that's being done methodologically. It's not a criticism, but just the way these requests for pre-authorization come in leads us to believe this is a question that needs to be looked at. And there should be an advance approval required for multi-service days if they're approvable under the current policy. We think there should be advance approval for a second instance of the same code on a given day. Again, same service, same code, same day, multiple times. Same reasons. It should be part of the plan of care, and again, it should be tied to outcome metrics. Outcome metrics for all services in this benefit, in fact, all Medicaid services to the extent that they exist, should be brought into play. We give an example here where for Medicare, for physical outpatient speech therapy, if there isn't progress, Medicare will stop paying. We use that as an example. We're not suggesting that as a solution to this immediate problem. However, when you look at, as you can see on one of the slides, what the expectations for the benefits are now in your RSPMI benefit, they're extraordinarily broad. We think they should be behaviorally based and taking a look at that somebody needs to pay attention to some support in conversation with the current ASO vendor to how can some measurable outcomes be brought together as quickly as possible. We believe that there should be the development and implementation of the behavioral health quality system, including auditing of the master treatment plans. This is auditing of the master treatment plans that exist for each child, including the pre-authorizations of the ASO. This should include a report of results of services in the care management outcomes, to the extent that there are care management outcomes listed in the master treatment plans. 2 types of audits: one to discover system deficiencies in compliance, to find variance from policy and effective practice to the extent that it's defined today, and develop and implement new penalties associated with policy and audits when there's non-compliance. So those are the things that we think could have some immediate attention and be implemented within 6 months.
Do you have an opinion on what would be necessary to implement these policies, real changes through the legislative process?
Specifically, no, but I think the process needs to be is the DHS needs to sit down with and DHS, I'm including MDS and DBHS, to sit down with the ASO vendor deacons and go over these recommendations and look at what they conceivably could do under current rule and current policy. I think from that analysis, they're probably going to come up with some ideas that they could, if possible, do an immediate basis without any change in rule or policy, and then perhaps some that require rule and policy changes that would have to come back to the legislature and then make a recommendation off of that for the short term.
John, can you speak to whether or not these recommendations that you see here are feasible and implementable with the current system we have?
Mr. Chairman, Dr. Charlie Green's our Director of Behavior Health.
Again, I'm not saying that we make a recommendation either. I just want to know mechanically, this is an example of a regulatory or rule change. I want to know how hamstrung we are as a department of this for stuff like this.
Charlie Gray, I'm the Director of Division of Behavioral Health Services at DHS. Mr. Chair, we'll be happy to sit down and visit, as Richard said, visit with our colleagues over Medicaid and also with folks at the governor's office to see how, and VO, and see how, what of this is possible, what is possible through practice changes at VO Beacon, what's possible, what we need to bring back to the legislative process, and how those changes might fit into the vision of what the governor's office has for us to bring over here to propose as an overall change. That being said, let me make sure I put this in the context. We worked hard with these guys, and I think they've done a really good job of digging into what some of the problems are and pointing out that we're very lax on outcomes-based measures, and we don't have good system of assessment, and we don't have good care management. And that's the thing we proposed about a year and a half ago, and couldn't really get any traction, and then ended up waiting on this process. But we want to make changes and want to be more accountable, and want to make sure our dollars are spent helping, especially with the children and both adults as well, to make sure that we're helping them move forward as best they can. So, that all being said, we'll be happy to sit down and look and evaluate what we can do, and like I said, meet with our bosses and see how we might proceed. We have to come back and report that to you next month.
I think that would be good. Again, when I look at page 39, it says implement these within 6 months. I know that what we normally tend to do is talk about things for 2 years and then not implement them. So what I guess I would ask you to do is, whether or not, the governor's office or the task force or whoever decides to actually implement these things, I think it would be very valuable for us to know if we did say that, yeah, we see this as something that would, just as we talked about with the pharmacy changes that DHS has already made, could provide immediate savings and assist with any detection of irregularities. How would we do that? And what are the impediments to doing that? So if you would mind gathering that together for us for the next meeting, I think it would be helpful. We got a couple of questions though before you take off. Senator Sanders, you're recognized.
Yeah, thank you, Mr. Green, if you could too, I think it would be beneficial if you could bring the previous changes that we tried to make in terms of trying to put some sort of rational management and practice on this program. I guess it's been about 2 years, and maybe some narrative as to how the rules process, regulatory process, state plan amendment process was sort of short-circuited, and the concerns that were stated. I think that would be really important for members to see in terms of how we decide to move forward with management. Is do we want to continue to set ourselves up for failure? One of the questions I asked the governor is, as we move forward, are we going to put some tripwires or some benchmarks in place if we see sort of the same old behavior of, okay, well, we'll say we'll reform, and then as we get down that path, people start backpedaling, and we'll put some triggers in place. But I think that would be really helpful to sort of cast the narrative and give sort of a historical perspective of, we've gone down this path before, so we'll see.
I agree. It would be bad.
Representative Rob.
Didn't, a couple of years ago, didn't you, become part of local reform, basically do what they're trying to do now?
We put out for public comment as part of our process, right as I started in this job as an interim in the fall of 2014, the pushback we got during the public comment section of the process showed we weren't going to get there, and y'all remember that. At the end of one administration, we were getting ready to change over, and everybody decided it was just best to wait. But the framework of the performance is the same. I think the real difference comes down to whether you hire an ASO and pay them to manage the system, or you go manage care and put them at risk, as Mr. Seeley talked about in the last meeting.
But you have a well framework for
Yes, and we actually made some changes in what we put out there. We got some really good comments, and we had a good dialogue, but when you start talking about the things that Richard and John have outlined here today, which was what we proposed to change, the independent assessment that's going to decide level of care, that's a pretty severe change for us. It's a necessary change. We believe it's a necessary change, but that made people want to dig their heels in and kind of wait to see what was going to happen with overall with Medicaid and with the new administration.
Yeah, staff just informed me that, yeah, it'd be just do the standard rules of procedure that we normally go through. As you start a public hearing, then it goes to rules and regs and ALC. And I think there's going to be a lot of interest on how those things get held up or don't, or get passed over the next few months. Representative Hammer.
Thank you, Charlie. You mentioned about public, right in front of you, mentioned about public comment, pushback. Where did the pushback come from? The public comments were directed from what area?
The main pushback we got was from provider associations that, like I said, it was quite a change to go to have a whole nother level of assessment, and then to, out of that assessment, to come those tiers of service. You've heard described what we do now and some of the shortcomings associated with it. Now, let me say, the folks in the field that are trying to take care of these children and these adults, they work hard. We don't have any reason to believe they're not really dedicated to it. We've set up a fee-for-service system that does not end up with really good outcomes, nor a way for us to know if there are really good outcomes. And so mostly that, we did hear from some advocacy groups that are always concerned, a little bit concerned about changes if they think, oh, well, now is this really a way for the government to exclude some services that we have now? But we actually proposed to add some therapeutic community services, things that we don't have now that help people get out of institutional care and get out of really expensive residential treatment.
So is it fair to say that we've come full cycle in 2 years to where now we are right where we were a year and a half ago now, that we're just hearing it from a different source?
Yes, sir. I think so. I think we certainly have more momentum for change right now because the pressure is more. We were talking about what might happen back in 2014. Now we're talking about what's actually going to happen with regards to the budgetary impact of doing nothing.
Thank you, Mr. Chair.
That's all we have. That's all.
Okay, Mr. Chairman, I'm on slide 41. We're moving into a little bit longer term perspective, and what I would ask is that we kind of reframe. This is a complete transformation recommendation of the RSPMI benefit to evidence-based practice, best practice services. Essentially, this would wipe the slate clean and start over again in your behavioral health rehabilitation option. The goal would be to improve clinical effectiveness.
Hey, Richard, would you pull your mic a little closer there?
Excuse me, thank you. The goal would be to improve clinical effectiveness, cost efficiency, and care management, integrate care management into the system. Change the Medicaid manual definition of medical necessity to enable effective care management strategies in all settings. Transform RSPMI essentially into an adult behavioral health rehabilitative benefit and a child-adolescent behavioral health benefit. There will be two different benefits here in construction in your public mental health system. We would recommend you implement research-based, evidence-based behavioral health treatments and known best practices effectively used in other states for the adult and child-adolescent population. I just want to be clear, we're not big believers in every single piece of research coming out of every university with the number of people that have been studied is 19 and 20. We're talking about the major studies that have resulted in evidence-based practice, such as illness management recovery. That's important that you pick evidence-based practices that are real, well-tested. You can talk to other states and providers how they work, and what the credentials are required, and what the timeline is to develop that kind of system and how you ramp up over a period of time. We would recommend you redesign the RSPMI benefit through a truly inclusive stakeholder process that is led by an independent facilitator. With due respect to the work that's been done, we think it's great that you're looking at what Charlie and the department was working on. There's a lot of good stuff in there, but we would kind of recommend you keep that as part of the slate, but move forward on a new slate. And if those come to the fore and that's the final plan, great. We think you need an independent facilitator, frankly, because there have been too many interests involved here. An independent facilitator would level the playing field between the state, the providers, the families, and just give you an opportunity to hear independent recommendations on how to make this benefit work. We think you should develop and implement an Arkansas approach to coordinating the mental health rehab option services with the Arkansas State Hospital. We've been here for several months, no one talks about the state hospital. That's a key cost center, it's a key public safety factor, it's got a lot of forensics patients in, as you know, but you also have the 6th smallest number of beds per 100,000 state psychiatric hospital beds in the country. You spend $145 million in Medicaid for inpatient psychiatry and RTCs, and that's for children. We've been told there aren't any inpatient psychiatric days being paid for by Medicaid for adults. We didn't find that when we did the data scrub. So we think you definitely need to bring Arkansas State Hospital into the dialogue. And as Charlie said, how do you avoid admissions? How do you get discharges from all psychiatric facilities, but particularly Arkansas State, because that's probably where you're most stay.
Okay, mark your place right there, because Representative Hammer has a question before we get too far down the road. Representative Hammer, to recognize.
Thank you. Could you just inform me, because I'm not quite sure how they fit into value options? You're talking about accountability component, somebody, all that. What purpose does value option play then in all this, if any?
I'm being agnostic now about any current construction in the state and what any entity might play in the future.
So are you saying, if you feel free to comment, that the system that we have now, including them, hasn't adequately achieved what our goals are, or what are you saying? What I am not saying is that the vendor has or has not met the criteria that we set up for them in the contract. We think, from what we've discussed with them and learned, and haven't heard anything to the contrary, that they are living up to the terms of the contract. What we have been discussing is that the terms of the contract are inadequate to meet the criteria of assuring effective clinical practice, appropriate treatment, cost efficiency, and outcomes. What I'm talking about right now is completely transforming your current RSPMI benefit that value options now is the ASO for. So they've been performing up to the function of what the contract required. You're talking about changing the contract, which will change their function.
I'm talking
Maybe
about,
not.
I'm sorry if I don't understand, sir. I'm talking about changing the clinical benefits that the contract currently manages. I'm talking about changing RSPMI. I'm talking about getting rid of RSPMI.
Okay.
And redefining what your behavioral health rehabilitation option benefits would be for adults and for children.
Thank you.
Again, we think that you need to have an Arkansas approach in all of this, but this, again, Arkansas State private psych hospitals, the RTCs, need to be part of this dialogue and need to be integrated into the future rehabilitation option benefit that you may or may not change, hopefully change. We think you should develop and implement an Arkansas approach to coordinating. This is really important. Behavioral health needs of children and adolescents in foster care across inpatient and outpatient. This is really critical. We weren't asked, but we have no doubt, and John and our experience in other states, both running child protective service agencies and working with states and advising them on, that you have a significant number of foster care children that are in and out of this behavioral health benefit, and certainly are in and out of inpatient psychiatric services in their RTCs. We really suggest developing an Arkansas wraparound model and including that in some manner, shape, or form into your behavioral health benefit for children in the future.
We definitely, and we've been over this, we really suggest strongly require a behavioral health acuity assessment instruments administered by qualified independent professionals for adults and children and adolescents. This is the independent assessment. We think the individual master treatment plan and level of service is duration, amount, scope, and should include outcomes to be based on the acuity level, just like Charlie was talking about before. Maybe that model, maybe a different model, but we should definitely do this. And the independent assessment needs to include the independent assessor taking some measure of what the patient's immediate circumstances are, person's in crisis, et cetera, so that can inform the actual assessment instrument and any information the individual assessor would have.
How's the assessment process work now?
To my knowledge, it's basically a process where a provider may meet a client and doing a verbal assessment or whatever assessment that they do in their office. They put together a file, a client file, name, address, demographics, past history to the extent that they're known, and a clinical narrative, a narrative. That's what goes to Value Options, and they review the background information and the clinical narrative. The clinical narrative is where they make the determination of medical necessity. Now, there's some, that's a process that has been used historically, up until maybe 20 years ago, generally speaking, in public mental health, until the ability to assess levels of acuity in danger to self or others became more evidentiary-based and to some extent actuarially-based with some tools to assess levels of acuity, and states have tied level of benefits to the level of acuity. Number one, you want to make sure the right benefits go to the right people with the right needs to meet the right benefits, and frankly, for effectiveness in terms of measuring outcomes in relationship to a more refined definition of what the services are and to control costs.
Do most states use independent evidence-based assessments?
I don't know if most states do, but I'd say at least 25 of them do. And some of them will be done by managed care companies themselves, where there's an integrated construction. The state may or may not identify the individual assessment tool. There's a handful of tools. If you go to states now for children and just mention CANS, you're probably going to find 32 of them that are using CANS, either in their public mental health benefit, their foster care system. State of Texas just adopted CANS through legislative mandate that's going into effect here, I think, in the next year. And also construction of the CANS and the mental health benefit. We use the CANS in Washington, we use it in both the mental health benefit and in foster care in Virginia, they're doing the same thing. We strongly suggest, as we have throughout, we require an independent qualified organization such as an ACO, given the Managed Key Service Research we're doing, or an MCO, as we've recommended in the past, to manage the benefit, and to include the inpatient services, the level of risk across the system. So whatever system you go in terms of managing the system, we recommend the general principles that John offered here earlier today. Outcome measures, I'm not going to go into the details. There's a plethora of outcome measurements that you can use. I would suggest you cut to the chase and look at the NCQA HEDIS data. They're expanding their mental health outcomes. Also look at the SAMHSA instructions, which is the Substance Abuse Mental Health Services Administration. They have a library of outcome measures that are used throughout the country and in the world to some extent. And a quick look at the Institute of Medicine. You also need, for outcomes, you need to think about training in advance to your provider systems, allowance for corrective action, accountability. I think that's where the level of risk comes in. Whatever risk method you use, and tiered consequences for non-performance, obviously, the ultimate one being pulling provider license. That's at a different level. I'm talking here clinical outcomes. And we also think the DHS must assure that DMS and DDH work as a team to get this done in the short term, being the next year or so, given that there's a lot of questions about where DHS is going and what the organizational structure might be. We think strongly enough about this that DHS, DBHS, and DMS should be empowered. They should be required to develop a comprehensive plan, to plan how to do this, if you will. I hate to go back to plans to plan, but considering where we are, that probably would be the best way and the clearest way for you to get the information that you would want and need and have a chance to ask questions and deliver that back to you perhaps in 60 days. And from that, if you decide to go down this road, I would think you could get this implemented in 8 months if it was an all hands on deck construction.
If I could just add to that, Mr. Chair, I know in speaking with Dawn at EMS and the staff there that the governor's office is also working with them on the issue of behavioral health and savings and identifying certain areas under his mandate. And what we want to do is make sure we work together and that whatever we present is consistent with what they're looking at too, because I think working together is going to be the best format to move this. And it may not be 60 days, it may take a little longer, but it all should be a coordinated effort, and I think it's going to benefit you in the long run.
Yeah, I guess I guess what I'm asking is you would expect this would be one of your recommendations that you'll be bringing forward at the March meeting when we try to take action on the recommendations, because you pretty well spelled out that you think that they should do this and bring it to us within 60 days.
Yes, well, our thinking was on that. First of all, I think we want to find out first what they're working on for the governor and make sure it's consistent, if we feel it's appropriate. But I think it's important, when we come in February with a management fee-for-service type entity approach that we outlined today, that we're going to include significant number of behavioral health savings. I mean, it's going to be pretty clear to us. We know the areas that we think need to be fixed and can be fixed. And that's why I've said to you, it's going to be dependent upon your ability to say, okay, but these rules are going to be, if we're going to make these savings, these rules or these things have to change. That's why I want to look at that constitutional issue for you. I want to be prepared. But I'm saying the next meeting, we're going to have identified some behavioral health savings based on what other states have done. And in those savings is going to be impacted a lot of these changes that we're going to assume. So we want to make sure the department is working with you all in moving forward. If there are things they don't agree with, we'll take that into consideration. Within that 60-day framework, it may be further. In February, we'll have more information for you. We may be able to come to you with the department saying, these are the definite things that are going to happen. Yes, they can start following the rules. They can make changes on non-rules, just practice like Charlie said. But there are things that they're working, just like what Rory said today. So I want you to know that we're going to continue to work on this. But I think in our savings estimates, we want to be able to even come back sooner with an idea that some of those are going to involve these changes.
Would you say that if behavioral health were put into a managed care type of a arrangement, one of the first things a managed care company would do is what you're talking about right here?
I don't think there's any question. I'm absolutely.
So, in other words, what you're bringing us with this and some of the other recommendations are some of the things that should happen, whether it's through managed care or whether it's something that the state does internally.
Yes, and I would just state that without some of these changes, you may not have interest from managed care companies to come into Arkansas. I don't know. But I can tell you that the rules are important. And if it's a management entity that you're going to hold responsible for at some level of risk for making those savings happen, they're going to want to see those changes.
Right.
So, yes.
So any RFP or type of negotiation with a managed care organization is going to require some understanding of what rule changes will have to be made in order to allow changes like this to occur.
There's no question, but most states that have done this have done it usually in an omnibus bill, where you say, like Texas did this, they passed a bill that allows for managed care. And while they're doing that, they'll identify other areas, notwithstanding any other provision of law.
Right.
And, then the managed care entities can work, or the managed fee-for-service entities can work on a clean slate.
Do we have are you all finished with this section?
Yes. And I know that was a lot, but I apologize to take you through a lot today, but it's very important.
Good. And I see we also have Dawn and Elizabeth on the agenda. Are they here? Do they want to speak to this? Oh, and while they're coming down, Representative Ferguson, I see you recognized for questions.
It's not really on this, but just before we leave for the day, Senator England and I had met with DD people, we wanted to know if it wasn't too much trouble if the Stevens Group could bring us an actual cost analysis of some similar states to Arkansas on their total DD spend.
Yeah, if you guys can handle that, right? You bet. Okay, Don and Elizabeth, come on down. Welcome back. Elizabeth, Don, if you just state your name for the record and both recognized to comment on item E.
Don Staley, Director of Division of Medical Services. I'll be brief given the time. I think certainly just to echo a lot of what Dr. Green had said, definitely I reached an opportunity within the program, certainly some of those which the Stevens Group has highlighted. I think it'd be helpful to spend some more time with the Stevens Group, digging into the data, understanding what are those opportunities, and then coming back to this group and then talking about how we may want to move some of that forward. So with that, I'll defer to Elizabeth on any comments she'd like to make.
Okay.
We have, as I said before, we have already started looking at this prior even to the report that we received. We started looking at the group therapy code, 90853. One of the ones they mentioned here. Don Stephen had it at, I think, 51 million for 2014. We've been working with our zone program integrity contractor. CMS provides a contractor who works with both Medicare and Medicaid, and they give us advice and review data across the nation, and they see Arkansas as an outlier in behavioral health, and specifically in this particular group therapy code. We believe that
What do you mean by outlier? In what way?
We spend more than anybody than the others, and so we utilize the term outlier for when OMIG goes to investigate and to determine who to audit, basically like a provider. We will look at the billing for all providers in a particular area, and we'll see if one person bills higher than someone else, then we would consider them to be an outlier. They're higher than the norm, I guess. So Arkansas, according to our zone program integrity contractor, they've done some analysis. I'm actually going to be meeting with them later this afternoon and have some more time with them tomorrow, where they look at other states, how they bill, what their benefit is, how many units, how long our units are, whether we have limits. These are some things that the Stevens Group also mentioned. But it's my understanding that in 2015 it was more, they see 2014 numbers as 51 million, 2015 I think that's going to be higher. So I think that is, I think the group therapy is an opportunity. I think all of behavioral health is a large opportunity to find savings, and making changes to the whole benefit is likely necessary.
Let me ask both, or primarily you, Dawn, on this. What would have happened 2 years ago if you'd have brought legislative rule changes to go to evidentiary-based independent assessments?
Really a lot of what the Stevens Group has outlined is conceptually what we had proposed in working with stakeholders over the past couple of years, things such as independent assessments, looking at increasing care coordination, primarily through the use of health homes. I know that's something that we talked about today, and really focusing on the outcome measures, tying that both to payment as well as potential for shared savings, and even looking at opportunities for risk in terms of putting a portion of that per member per month payment at risk within the health home setting. So I think there's a lot in terms of what you heard from the Stevens Group conceptually that we believe aligns with what had been proposed.
And what happened to it, I guess? Why is it not there now?
Well, I think as Dr. Green had testified, I think at the time when we've done the public comment period, and based on that feedback, I think there were questions about, given the fact that we were undergoing a change within the administration, as well as some of the comments we got from providers, basically had been asked to kind of go back to the drawing board take a look at where we could make some changes, and then look at bringing back a proposal. And I think as Dr. Green had indicated, some changes had been made to that proposal, and I think it's really that at this point, I think the discussions were, well, let's, you know, something the task force is going to look at, so let's see what the task force looks at with regard to this area, and then determine, you know, based on what you all have looked at, what the department's been working on, you know, where we might be able to come forward with then an overall recommendation about what to do with the program.
Okay. Any other comments from y'all or questions from the members? Okay, thank you all, appreciate it. We're going to move on to item F. John, you still here? Update on the Arkansas Work Proposal Waiver discussions and status of the dental program RFP. 2 items they're going to give us an update on.
Mr. Chair, are you talking about Director Seelig or this John?
I'm sorry, John Stephen. That's what I have on my agenda here. Maybe it's supposed to be John Seelig. Who's been talking about Arkansas Works?
I think it was meant for John Seelig.
Don, why don't you come back? Oh, you're still there. Okay, Don, tell us what's going on.
Certainly, I'm happy to take it off, and then between John, Mark, or John, Stephen, we can continue to expand upon that. I think as a follow-up to discussions at last month's task force meeting and the corresponding recommendations, we moved forward with what the governor had outlined to the task force in terms of his vision for Arkansas Works. As part of that, we did go ahead and submit our initial application to CMS by the end of December 31st, really letting them know 2 things. One, that you know, it is our intention to basically move away from the private option, and that the program that we know as of today will no longer be in existence as we look at 2017, but also really outlining the intent to then look at creating a new program in terms of Arkansas Works, really focusing on supporting employment, promoting integrity, as well as personal responsibility. I'm happy to talk through that more, but basically within that letter and that application to CMS included many of the things that the governor had spoke about in his address to the task force at the last meeting.
Okay, so the request has been sent, and I guess they're going to visit, and we did get confirmation that the governor will come back and report to us on the 17th. So we'll know more then about what of those provisions have been approved or not approved, or Dr. Dig maybe. So, okay, any other questions for Don on Arkansas Works? Okay, I think we're really done with you now.
Well, I think my name's on the dental one too.
Okay, give us, are you doing the dental, or John, are you going to speak to the dental, or just John?
Well, I mean, I think that the agenda item reflected the department may be moving forward on an RFP, and there's just, the task force want to know the status.
Okay, there you go. Give us the status update.
Certainly. Much like our previous discussions, we are moving forward with developing a plan to transition the administration of the existing program in terms of dental to one that is fully capitated, risk-based managed care, much like you heard John Stephen describe in his testimony. To facilitate that process, we've asked Manat, I think who we've talked about before, who's been assisting with the private option and then going forward Arkansas Works, to assist us over the next few months really on a few key items, assisting with drafting the RFP, identifying the criteria for vendor evaluation and selection, and then supporting the development of the corresponding contracts, among other activities. As such, that will be an amendment to their contract, so we plan to bring that over to next month's review committee. And then in the meantime, we're just working on developing a roadmap of next steps and a potential timeline for implementation. Obviously, there's a lot more, as John Stevens mentioned, decisions have to be made, things we need to get feedback on about what exactly the new program will look like. So that's part of what, between our folks, the assistance from Manat, and then working with stakeholders, hope to be able to dive into some of those issues and be able to outline what types of things to include in the RFP.
So the RFP will be put out just like any other RFP with anyone able to competitively bid on it. We'll go through the normal contract review process, and approval.
That's correct.
Is it going to be a fully managed care type of a RFP, or what are we looking at?
Yes, based on our understanding of the discussions and feedback from the task force, the corresponding recommendations, at this point, we are moving forward with a fully risk-based managed care RFP.
Senator Elliott, you recognize.
Well, I'm right here. I hope this is not redundant to everything you just said, but do you have any reason to suspect we might end up with a sole source contract, considering that you are going ahead with an RFP?
I honestly don't foresee that happening. I think that, this is a type of administration that many states have implemented over the years. I think, as of today, I think there's over 30 states that have some type of managed care arrangement for their dental program. So, certainly there's no shortage of interest or vendors from that perspective who I think are likely to bid on this. And I think it'd be really difficult for a particular vendor to say that we are uniquely qualified to provide this service for the state of Arkansas. So I think as the chairman said, in terms of going through the process of procurement, review, and then ultimately coming to you all for approval, I just don't see how that would be the case.
And there are not any dates or anything that we're up against that might cause the same thing to happen, that we suddenly have to have a contract okay, because that's something we run into a lot in review.
Right,
As a sole source.
Yeah, I think that in terms of, transitioning the traditional Medicaid program, there really aren't set dates that we have to work around. I think certainly as we discussed around the dental changes that are in place now for the MMIS system in terms of claims processing to dental, that is something we've been working with HP and will continue to work on to make sure that we're can avoid any duplicate programming if necessary. But beyond that, there's not a specific time frame per se by which these changes have to occur. I think our goal is to try and implement the new program within 2017, but there's not a particular deadline that we have to meet that would require us to take a different course with regard to the contract.
Okay.
Any other questions? Okay, I think that's all we have on the agenda for today. We are scheduled for So we have finished the agenda and we are adjourned. Thank you all. Members, just to clear up, we are not meeting tomorrow. We finished the agenda today.
No, you're fine.